Yep. Good afternoon. I'd like to call the Population Health Committee to order, and today is March the 3rd, 2026. Clerk, would you please open the board for roll call? Okay, Clerk, would you please close the board and announce the roll, please?
Madam Chair, you have 10 members present. You have a quorum.
Thank you, Clerk, and thank you, members. So again, I just want to say welcome. We have a full calendar today, and we want to be respectful of everyone's time, but we'll also take time to make sure we are doing the work for the people of the great state of Tennessee. So House Bill 0570 and House Bill 153 have been rolled at the request of the sponsor. 1534, I'm sorry, did I say it wrong? Okay. Okay, so House Bill 0570 and House Bill 1534 has been rolled 1 week at the request of the sponsor. And then also House Bill 2299 by Chairman Williams is rolled to the Hill.
2290.
It's got 2299 here. Is
It's
it?
a typo. It's 2290.
Okay. Okay. Yeah, sorry about that. There was a typo. It's House Bill 2290 by Chairman Williams has been rolled to the Hill. Okay. So with that, we will, has anybody got any announcements or any recognition they would like to add? Chairman Clemens.
Well, since this is the Population Health Subcommittee, I think we should welcome all the doctors who are having their hill in the day today. So welcome all the doctors.
And especially the ones out of Knox County that I represent. So, but thank you to all of you. Yes. Okay, so we will begin with item number 1, which is by Chairman Terry. House Bill 2075, and you have a motion and a second. So, did you have any amendments?
Yes, I believe I do.
Okay, would you like to give us the amendment number drafting?
014
014
072.
072.
Okay, thank you. Do we have a motion?
Second.
Motion and second. Okay, proceed with your bill, please.
Do we have to vote on it?
Did we vote?
Did you?
Did everybody in favor say aye?
Aye.
Okay, anybody opposed? Nope. All right, let's go. Let's go. Amendments on the bill.
All right. Thank you, Chairman and Committee. Thank you for the housekeeping and keeping me in line. House Bill 2075, the Helping Open Pathways to Effective Treatment Act, creates a structured medically supervised pathway for Tennessee institutions to participate in FDA-authorized clinical trials studying ibogaine for opioid use disorder, PTSD, traumatic brain injury, and other indications approved under an FDA investigational new drug authorization. So what is ibogaine? Ibogaine is a naturally occurring psychoactive alkaloid derived from the African iboga shrub. Ibogaine is complex and unique because it does not act on just one receptor. It works across several systems. It blocks NMDA receptors to interrupt learned addictive patterns. It modulates opioid and dopamine pathways to reduce cravings, and it enhances serotonin signaling to stabilize mood. And most importantly, it increases levels of glial cell line-derived neurotrophic factor, so GDNF, which supports repair and normalization of dopamine circuits damaged by chronic substance use and trauma. Together, these effects can blunt withdrawal, reduce compulsory drug seeking, and create a window of neuroplasticity during which patients may be more receptive to lasting behavioral change. And so this bill, in effect, does four things. It establishes a state council to oversee participation in legitimate FDA-regulated clinical trials for ibogaine. It allows qualified Tennessee academic medical centers and research hospitals to join a multi-state consortium conducting drug development trials. It creates strong safety requirements, including physician supervision, hospital-based administration, cardiac screening protocols, and compliance with an FDA investigational new drug authorization. And then if participating Tennessee institution develops patents, licensing agreements, or other commercial rights from an ibogaine clinical trial funded under this chapter, no less than 2% of the resulting revenue would be paid to the state under the contract with the coordinating institution, and those funds are then deposited into the state treasury with at least half directed towards the Emerging Behavioral Health Treatment Innovation Fund to support future research and behavioral health initiatives. And so thank you, Chairman. With that explanation, we have some folks here that would like to testify, and they can answer all our questions.
Yeah. So we do have some here to testify, and so without objection, we'll go out of session. And we have, let's see, Ricky Harris. See here? Oh, Ricky, I'm sorry. And we have Brian Hubbard and Alex West. So if all three of you want to take a seat, and does it matter who goes first? Okay. Ladies first. And we will give you 3 minutes to speak, and just tell us who you are and who you represent, and you're ready to go.
Great, thank you. Thank you for allowing me to speak today. My name is Ricky Harris. I'm the CEO of Tennessee Voices, and each year we serve 12,000 Tennessee families and providers who deliver over 59,000 service encounters in all 95 counties of Tennessee. We sit at kitchen tables, we walk into courtrooms and classrooms, we answer desperate calls for help. We tend to our clients around the clock, and we see firsthand what happens when addiction and untreated mental illness reach their breaking point. But I'm not just here as a CEO. I'm here as a granddaughter whose grandpa died by suicide. I'm here as a family member to a loved one who is living with a serious mental illness. I'm here as someone who has watched a loved one in my family fight to recover from opioid addiction, including Suboxone treatment. The issue is personal to me, and it's generational. And in Tennessee, when a parent struggles with addiction, it doesn't stop with a parent. It affects a child who's sitting in a classroom. It affects a grandparent stepping in to raise toddlers late in their life. It affects foster families, already stretched very thin in our state. Substance use remains one of the leading drivers of child removal in our state. And when relapse happens, court timelines restart, case plans reset, children accumulate adverse childhood experiences. And we know that ACEs shape the health, stability, and opportunities for our children for decades. Medication-assisted treatment saves lives, and we support it, but it doesn't work for everyone. And we now face an issue of treatment-resistant substance use disorder, a problem that we have not solved. The HOPE Treatment Act does not legalize recreational drugs. It doesn't override federal law. It creates a tightly structured framework for medical oversight, cardiac monitoring, institutional review, and data transparency so Tennessee, alongside Texas and other participating states, can evaluate ibogaine safely. The bill offers us guardrails. It allows us to study and not speculate, to protect and not experiment recklessly, and to lead and not send families across the borders to seek treatment that works. If structured research helps just a small percentage of high-risk families will be stable, and that means fewer removals, fewer foster placements, fewer children carrying trauma into adulthood. So as lawmakers, you are stewards of Tennessee's families. Innovation paired with this kind of accountability isn't partisan, it's leadership. When states act on the high stakes of children and families' outcomes, we can thoughtfully explore, and we can do it responsibly. I respectfully ask for your support for the HOPE Treatment Act. We can lead this with compassion and caution. Thank you.
Okay, thank you, Ms. Harris. And so Brian Hubbard.
My name is Brian Hubbard, Chief Executive Officer of Americans for Ibogaine, co-founded with former Texas Governor Rick Perry as the nation's premier public policy and advocacy organization devoted to the expedited medicalization of Ibogaine within the United States. I was raised in the Virginia coal fields, have lived in Kentucky since 1997, but was born a volunteer in Bristol, Tennessee, just a little over 50 years ago. After I graduated law school in the year 2000, I had a 16-year career representing Walmart, Tennessee Valley Authority, and Tyson Foods exclusively statewide in their workers' compensation litigation. These practice years coincided with the onset and explosion of the opioid epidemic out of Appalachia and across the rest of the country. I then led Kentucky's Social Security Disability and Child Support Enforcement System simultaneously, Kentucky's Office of Medicaid Fraud and Abuse Control, and then finally served as the first chairman and executive director of the Kentucky Opioid Commission. Over the last 50 years, Americans have experienced the mass extinction of family and community. Over the last 30 years, we have experienced the institutional criminality of systems which are supposed to serve and protect us, but have instead created the opioid epidemic, the gravest engineered humanitarian catastrophe to befall the United States since the end of the 19th century. The 2008 financial crisis, which forcibly dispossessed millions of us from the American dream and sent us the bill for the cost of our dispossession, a bill we and our children continue to pay. And deplorably, 24 years of unremitting, unmerciful warfare, which have taken exponentially more service member lives here at home by suicide than have been lost on battlefields abroad. Over the last 10 years, the sum total paid for this criminality has been 1.5 million Americans who have died from drug overdoses, alcohol-related disease, and suicide, a convergence of lethalities for which our veterans are ground zero. These deaths of spiritual despair exceed the total number of U.S. soldiers killed in action since 1776. 102 American counties have populations with life expectancies less than that of North Korea, and 80% of respondents to a recent Wall Street Journal poll expressed their belief that the American dream is dead. Over 700,000 American deaths of despair are attributable to opioid overdose. Based on 2023 mortality, at least 8 Tennesseans die of preventable opioid overdose every single day. In 2024, the most recent years for which statistics are available, Tennessee was second in addiction severity with an opioid use disorder rate 3 times the national average. The opioid epidemic now costs the United States $1.5 trillion annually and has a total cost of $11 trillion since 2000, almost 1/3 the total national debt. The opioid epidemic extracts over $2 billion per year from Tennessee and her people. And each diagnosis of opioid use disorder costs this state $808,000. 8 years of treatment over an average number of 5
Mr.
separate
Hubbard.
attempts.
You're past our 3 minutes. Are you close to finishing?
Yes, ma'am. 30 seconds,
Okay.
with your permission. 8 years of treatment with existing options yield exactly 1 year of sobriety. It is my hope that this state will volunteer to join Texas to turn the fulcrum of history and to deliver hope for every individual who is lethally estranged from the existence of their soul with this breakthrough medication. Thank you.
Thank you. Okay, Alex West.
Good afternoon. My name is Alex West, and I'm a 20-year retired Navy SEAL with 15 combat deployments. I'm also the founder of a veteran nonprofit and currently an associate mental health therapist here in Nashville. I joined the Navy at 17, and at 20, I became a Navy SEAL. At 23, I was the youngest person ever to go through SEAL Team 6 selection. My career reached its peak when I was asked to lead my assault team right up the middle of Osama bin Laden's compound. During the initial moment of the assault, my helicopter crashed during insertion, herniating discs in my back, an injury I didn't feel until hours later when the adrenaline wore off and the mission was over. But it wasn't the physical injuries that haunted me from my time in the SEAL teams. It was the mental scars, the weight of not just the bin Laden raid, but the hundreds and hundreds of combat missions I'd partaken in, the stress of war, and the deep-rooted trauma that comes with it. 2 years later, I was back in Afghanistan, but this time the war had caught up with me. I found myself sitting in my room with my assault rifle on my lap, contemplating ending my life. And as I sat there, the moment was interrupted by our base being attacked by the Taliban, ironically snapping me out of my dark moment as I manned the wall to help repel the attack. When I retired in 2018, I'd already been in weekly or biweekly therapy for over 8 years. But the trauma of war didn't go away. It only worsened. I suffered from night terrors, flashbacks, isolation, and a growing dependence on alcohol to numb my pain. But I kept fighting, I really did. I continued my aforementioned individual therapy along with weekly group therapy sessions at the VA. Psychotropic medication after medication, a total of 5 at its peak. But the suicidal thoughts only became stronger. Then one day, a close friend of mine who had been in numerous combat operations told me we were going out of the country for Ibogaine treatment. I'd never heard of Ibogaine treatment, and I asked him, why did we have to get out of the country? And he informed me that it was illegal here in America. But he pressed me. If I did not go, he feared I would not survive. I went through a 14-hour Ibogaine experience, and it was grueling, but it saved my life. And the results were profound. Today, I'm 6 years sober from alcohol and no longer on any psychotropic medications, down from 5. Many of my clients, as a therapist, especially those suffering from substance use disorder, PTSD, traumatic brain injuries, and suicidal ideation, would undoubtedly benefit from Ibogaine treatment, and it worries me that they may never get it. I stand before you today to ask for your support of clinical trials for Ibogaine. No American, veteran or not, should have to leave our country to receive treatment. I've seen the benefits firsthand, and I know it can help so many others. Thank you.
Wow. What a testimony, and praise God that you're here, and thankful that you were able to get the treatment that you needed. That's a testimony I don't know how anyone could vote against. So thank you for your service. Thank you for being brave to be able to come here and face us and tell us about your struggle and how real it is. So thank you very much. And so questions for our guest, Chairman Clemens.
Yeah, thank you, Madam Chair. And my question's for the CEO, I believe it was. Do your facilities also use mushrooms or any other psychedelic type of medications or legalized marijuana?
No, sir, we do not.
And why not? What's the, your state's not legalized those, or what's the limitation on those?
Well, first of all, Tennessee Voices isn't set up to provide that kind of treatment. Second, we wouldn't use any treatments that aren't legalized or in part of an FDA clinical trial.
And so what, I'm a layman here, so what's the difference between, say, a natural mushroom versus a natural Ibogaine?
Yeah.
How would that
I'm gonna,
differ?
if okay, I'm
aside?
gonna ask Brian Hubbard to answer that question.
Thank you, sir. And thank you, Ricky. Let me begin with, I'm a lawyer, not a mathematician or scientist. So with that disclaimer, here's what now years of study suggest to be the distinction between Ibogaine and perhaps psilocybin and the other rapid-acting therapies that you've read about. Ibogaine, for reasons that are not known, has the singular and unique capacity to restore the brain's neurochemistry to that which existed before an opioid user ever took the first pill. And when I say restore it, I mean within 36 to 48 hours for 80% of people who receive a single treatment. Ibogaine has the ability to reset dopamine and serotonin production, which is terribly and oftentimes permanently damaged in the brain of an opioid-dependent individual to that which existed before they ever took the first pill. Nothing is known to do this. And while I have great interest and appreciation for an emerging body of scientific research around psilocybin and some of these other what are called plant medicine treatment options, the difference between Ibogaine and the others is the difference between a 747 and a model airplane.
Well, 747s are pretty heavily regulated by the federal government, and they've been approved for pretty wide-scale usage. We obviously don't have that here with the FDA, and I understand that this doesn't go into effect unless it's approved by the FDA. Is there peer review studies? Are there clinical trials? And if so, what is the population of those? And do we know any of the results of those?
So that,
You're recognized.
thank you, ma'am. There are decades worth of observational studies undertaken in the United States and elsewhere, going back to the early 70s, which firmly established, again, through open label observation studies, that Ibogaine is a profound interrupter of addiction. There was a clinical trial approved by the FDA in the mid-90s, which was not executed, not because there was any sort of adverse event, but because the company which received the approval to conduct the trial fell apart due to disputes over intellectual property. The most recent and dramatic findings related to Ibogaine occurred within a 30-person observational study conducted by Stanford University, the results of which were published in the journal Nature Medicine on January 4th, 2025. These 30 U.S. Special Forces veterans had gone for Ibogaine treatment not for substance dependency, but for traumatic brain injury, as well as treatment-resistant depression, anxiety, a significant diminishment of functional capability, and suicidality. Almost all of these veterans had a cocktail of opioid and habituating psychotropic medications that they took with them leading into their treatment. The observational study at Stanford imaged veteran brains both before and after Ibogaine treatment. And as you all may know, there is not a medication of any kind that actually has the capacity to restore brain material. So each of these 30 U.S. Special Forces had objectively diagnosed traumatic brain injuries as demarcated by black spots that were throughout MRI imaging. After Ibogaine treatment, radiographic imaging revealed a series of just unbelievable findings, which caused the lead researcher to completely delete the data and reconstruct the entire study so that it could be rerun. And the findings were these. First, all of the black spots on the brain, which demarcated dead brain tissue, were gone after post-treatment MRI studies. The white matter that covers the surface of our brains, the highway across which all of our thoughts and impulses travel, grew and thickened in size. The center of the brain responsible for emotional regulation and executive functioning grew in size. And the average reversal of brain age among the 30 was 1.5 years, with the top 5 veterans seeing their brains reverse in age almost 5 years. This confirmed that Ibogaine has an unparalleled effect on the neuroregenesis of the brain itself, something that's never been known to be achievable by any science known to Western medicine. It is believed, and I concur, that Ibogaine is the most sophisticated molecule on the planet. And we are just now beginning to understand how it has dramatic breakthrough potential, not just for substance dependency, but for any number of neurological conditions that impact the brain for which we have no good answers.
Yeah, thank you, Madam Chair. So, I mean, this sounds almost too good to be true, right? So I guess it sounds like the silver bullet, for lack of a better term. But of course, there's a cardiac side effect that is acknowledged. So do you have a theory as to why this is not in common usage already?
Well, I'm just going to quote some Kentucky statistics for you as context. Between January 1 of 2017 and October 31st of 2023, Kentucky Medicaid, for a Medicaid population of 1.6 million people, paid for 110 million individual doses of buprenorphine and was billed over $1 billion by the primary manufacturer of that medication, a company called Indivior, a company which has a federal felony guilty plea of record with the U.S. Justice Department for engaging in an illicit scheme to increase the issuance of Suboxone prescriptions nationwide. Buprenorphine is a medication that was introduced as opioid maintenance treatment to titrate an individual into what was supposed to be abstinence. At this stage, that expectation has been adjusted to essentially lifelong medical management with the ingestion of that pill every day. An Ibogaine treatment is something someone may take 3 to 4 times over the course of their entire lives and does not lend itself to daily administration or to the usage of chronicity as currently exists within the pharmaceutical business model.
Chairman Clemens.
I'm good.
Okay. Does anyone else have any questions for our guest? Okay. Dr. Kumar.
Well, thank you, Madam Chair, and thank you for coming. And your testimony is very impressive. You gave us relevant information. Question, in which countries is Ibogaine legal at this time?
The country that is most renowned for its legality is actually it is Sao Paulo state within Brazil. The longest practitioner of Ibogaine medicine is a gentleman by the name of Dr. Bruno Rasmussen, who has been an Ibogaine provider for 30 years, primarily treating crack cocaine addiction in Sao Paulo state and with an impressive record of success. It exists in legally gray areas where it is neither outrightly legalized but not prohibited in Mexico and other countries in Central America. There is a nascent infrastructure in South Africa as well as New Zealand, but the overwhelming number of Ibogaine treatment options are underground. They do not have anything that resembles a standardized U.S. medical clinical framework, and it is a roll of the dice in terms of whether an individual makes it to a practitioner who knows how to administer it safely and efficaciously.
So if we were to compare it to buprenorphine, the current drug for addiction, and of course, treatment for PTSD being a separate matter, is Ibogaine also a substitute for addiction and is a lifelong treatment?
No, sir. By virtue of Ibogaine's mechanism of action, it does not produce effects in the brain which are biologically distortional. And by that I mean opioid maintenance therapy works so as to maintain an individual's opioid consumption at levels that allow them to be functional but prevent the onset of withdrawal. They do not restore the brain's neurochemistry to that which existed prior to the individual's consumption of opioids. Buprenorphine is a treatment of chronicity for what is a diagnosable condition that an individual may never fully recover from. Ibogaine's mechanism of action essentially resolves the neurochemical brain injury produced by opioid exposure by restoring the brain's chemistry to full and complete health and functionality in 80% of patients who get a single treatment. This is a curative treatment. It is the difference between fully extracting and resolving a cancer tumor and delivering chemotherapy to that tumor over the course of an individual's life. And that's the best analogous distinction that I can draw.
A single treatment having such effects, that's miracle, isn't it?
I would not go so far as to say that it is a miracle. It is certainly exceptional, and I would make one other important qualification. This is not a now and forevermore cure. What it does is provide an individual with the absolute best opportunity to reconstruct a shattered life with full biological restoration.
And how common are the side effects, cardiotoxicity being one? What is the nature of it and how common is it? How often does it occur?
The Ibogaine has a property that creates what is called a blockage of the Herd channel in the heart. And it can essentially, though a stimulant, prolong the amount of time that goes between heartbeats. What has been discovered by safe and efficacious clinics in Mexico, of which there are a few, is that the co-administration of Ibogaine or of magnesium with Ibogaine safely mitigates that risk. So when an individual goes for treatment, they'll be started on a magnesium drip at least 24 hours before their treatment. They're kept on a magnesium drip thereafter. And as long as magnesium is co-administered, it can be done safely. If an individual begins to develop a heart arrhythmia, usually there will be cardiac treatment personnel who will administer a medication called atropine that will put the heart into its normal rhythm. Dr. Rasmussen, in 30 years of treatment, has never had a single adverse event. And the rarity of those within an Ibogaine treatment certainly are far less than what I would describe as the adverse treatment outcomes associated with rates of relapse and overdose death connected to our existing treatment options.
Just final word. Thank you. Very informative. At this time, we are here to basically approve. I don't know if that's the right word. We don't approve drugs, but approve a study of the matter, right? And it would be under FDA supervision. So I think we are on the right track. Thank you again for your testimony.
Thank you.
Thank you, Madam Chair.
Thank you. And Chairman Terry.
Thank
Yep.
you. And I just kind of want to add and get Mr. West to kind of your talking about the process on this, and to kind of add on, it's there's essentially a pre-treatment, a pre-screening, heart conditions, but also from a mental standpoint, and you're essentially getting the patient ready for the treatment. And the treatment, again, during that process, again, they're would be medically supervised. They have the IV, and then afterwards there is the process by where, now that they have that window of neuroplasticity, and you have their the chemical balances now back restored, you put them in the right frame of mind, and the psychological treatment for them afterwards, so that they put themselves in the right frame of mind and in the right environment. So could you kind of discuss that?
Absolutely. Yeah. And thank you for the question. It is, from a behavioral health and from a mental health standpoint, it is so crucial that we do the preparatory work within this medicine prior for a client to go through the experience. And what that might look like is meeting with someone like myself, a mental health counselor, to go over things that, one, how can we identify things that you want to get out of this treatment? Okay, and then setting us up for the experience with things that can soothe your own nervous system, from breath work, meditation, and things like that. So we're not, it's just not a magic pill where we just take the pill and you're good to go, leave. It's more of like a very intensive, maybe 4 weeks, maybe even longer, time with a licensed mental health therapist to then prepare you. Then there's the experience. And then afterwards, there's aftercare that can go on for a month, 2 months, or perhaps even longer. And why that is so important is, now that we have taken those old neural pathways, we don't want those old neural pathways to get activated again. And so by making sure that those clients, they don't fall back into, let's say, using drugs, toxic relationships, stress at work, and on it goes, if you're supported by a mental health therapist, it will really set that client up for success, to really maximize the potential of the medicine.
Thank you.
And I guess I've got a question maybe to ask Mr. Hubbard probably. So as with anything, there are risks. I mean, you can take Tylenol or ibuprofen and have allergic reactions and all. So, I mean, obviously, and it's like with chemo, since we mentioned that with cancer and all, there's always side effects. And so with this, it seems to be that maybe one of the main ones is cardiac arrest, or seizures can happen, and it has to be, would you say it's got to be really, any patient going through this type of procedure or medication or whatever has got to really be closely monitored before and after for a prolonged time? You all would agree? I mean, it's not just like a real quick, simple thing. As with everything, there's side effects and things that can happen. So,
Would you want to take that first based on your experience?
Yes, yes, ma'am. It is very important for that clinician post-treatment to really be keeping an eye on the client and symptomology that might be coming up. And then from there, if needed, referring to a physician or whatever that client might need. And it's also what we are basing our clinical or our studies on is what has happened, Mr. Huberman mentioned at Stanford, that therapeutic framework. So there's preparatory, there's the experience, and there's afterwards. And during that after period or that integration period is going to be a very good time for that clinician, that therapist to really be keeping an eye on it, to support that client. And so that's just another reason why we believe it's so important to get that aftercare, to keep an eye out for those symptoms that perhaps might come up.
Okay, Mr. Hubbard.
In terms of the administration of the treatment itself, an individual always undergoes a panel of screening, whether that's psychosocial testing, blood testing, urinalysis, as well as EKGs to determine whether or not there are any inherent risks based on the health of the person's heart that would make treatment prohibitive. If an individual clears screening, the actual acute administration occurs over the course of what is essentially 36 hours. An individual will be given 2 to 3 pills, a milligram dosage based on weight. That person will be continuously monitored by medical professionals who are monitoring the heart. They will be kept on EKGs. Magnesium will be administered intravenously throughout the course of the treatment. There will be a very physically difficult 12 hours that are associated with the natural side effects. And those physically difficult 12 hours involve the onset of a significant ataxia or state of semi-paralysis, where an individual would require assistance to be able to move and be taken to a restroom or whatever. Oftentimes, for 85% of individuals, sometimes more, there's what is called the purge. A person will throw up continuously, oftentimes throughout this treatment. At all times, a person is fully and complete in control of their individual cognition, which is another distinction between this and some of the others. Ibogaine is a respecter of your free will, and you're going to know where you're at, who's around you, what's going on. If I were to take Ibogaine right now, I'd have to lay on this floor, and I'd have to have somebody help me sit up. I could have this conversation with you. But if I close my eyes, then there will be a very unique, though there are common themes, experience I have that will be very much related to my individual personal history. And that is the unspoken part that I believe that is oftentimes the anchor of the medication success and what makes it so spectacularly unique. And then after treatment, there's another 24 hours where a person really feels rough. Think about the flu times 10. And usually, 48 hours from treatment, you start to feel a little bit better physically. And then, what would you say, maybe 72 hours later, oftentimes the overwhelming majority of people feel the best they have ever felt in their life.
Well, thank you all very much. Justine, you got another question? Oh,
Thank you, Chair Lead. And, the question being about risk, and I just want the members to know that, right now there's veterans that are going outside the country, and, there may not be the strict protocol that is there that can protect our veterans or Tennesseans that may be going elsewhere that are dealing with these issues. And so what's going on right now, obviously it's a Schedule 1, but there is a process to get this through the FDA to get an FDA trial. So there's like the preclinical safety work and then the investigation on the new drug application that has to go in. And then once you get that in, there's the FDA review, and then there's the study, the site approval, and then there's the ethical guidelines that go along with this. And so what we would end up doing, to their point, is have when they do these studies, it's going to be going through all that. So yes, with any drug out there, there is risk, but that's the point of this, is that we're not putting our veterans and our other patients at increased risk, and that we would have those protocols in place here.
Has anyone else got any questions for our guest? Okay, seeing none, thank you all very much for coming, and you have definitely shared a lot of knowledge here, so we appreciate it. Thank you. We'll go back in session, and we will hear from Chairman Terry.
Thank you. And they did a great job in presenting all this. And, this bill positions Tennessee to lead in responsible research while protecting patients, supporting veterans, and addressing our opioid crisis with scientific rigor. This is obviously a research bill. It is a safety bill, and this is a hope bill. And I appreciate your vote.
You got questions for a sponsor?
Yes, ma'am.
Okay, Chairman Clemens.
Thank you, Madam Chair. Sponsor, have we heard from the Department of Mental Health on this? Do you know where the Department of Mental Health is? I'm surprised I haven't heard from them. Are they good with this bill? Are they willing to take on these responsibilities?
Chairman Terry.
Thank you. And I don't know exactly what their comments were, but on the original draft, we had a meeting with them, and this amendment came out of that meeting with mental health.
Chairman Clemens.
Does that mean they're a yes or a no?
Yeah,
or
they're
a
good.
wave?
They're good. I got the thumbs up from that they were good.
You got any more questions, Chairman Clemens?
No, ma'am.
Okay, thank you. Does anyone else on the committee have some questions? Okay, it's been brought, question on a bill. Is everyone good with that? Everybody ready to vote? Okay. You got a motion and second for question on the bill? All in favor? Okay. So clerk, would you please open the board to vote? Clerk, would you please announce the vote?
Madam Chair, you have 8 ayes, 2 nays.
Okay, this bill is moving on to full health. Okay, we're going to go without objection. We're going to go out of order and go back to our original agenda and bring up item number 2 by Chairman Williams, which is House Bill 2290. Do we have a motion and a second? Okay. He did, but he had to go ask, yeah. So since he is the vice chair of our finance, we thought we might ought to get him in. He might have a meeting he's got to run to give us some money, Clemens. Anyway, so you've got a motion and a second, and I believe you have an amendment, which is an untimely amendment. And since next week is supposed to be our last committee meeting, we're going to take a vote on if everyone wants to accept this untimely amendment of 14612. Is everyone good with got a motion and second for this amendment to be added on? Second? Okay. Okay. Do we have a copy? It's supposed to be on the dashboard. We're looking to see here. Chairman Clemens, I do have my copy that I'm more than willing to share that with you. Yes. Oh, it's not on the dashboard. I'm sorry about that. Well, I did have a copy. Okay, he's putting it on there now, but okay. But I'm more than happy to share that with Chairman Clemens. Okay, so we all vote to put the amendment, untimely amendment 14612. All in favor? All opposed? Okay. Your amendment is added to this bill, and so it's been put in proper order, and I believe the amendment did make the bill. Is that correct?
Yes, ma'am.
Okay. So we'll now let Chairman Williams explain his bill.
Thank you, Chair, Lady, and members. This was a multiple year effort of discussion regarding IVF and SARP policies as it relates to the delivery of this important health care to citizens across the state. Before I get started, I just want to say a word of thanks to Nashville Fertility Clinic. I know many of you, and myself included, had visited their facility here in Nashville over the summer in an effort to try to better understand what it is, the bill that we have before us. I'd also like to thank TMA and Julie Griffin and Zoe Sams for their difficult work. This amendment that you see before us is our final attempt at language. It was sent directly to me from them with one change, but I'll tell you what the bill does, one minor change. I'll tell you what the bill does. What we found because of what happened in Nashville several years ago regarding the closure of an IVF clinic, the Attorney General had to intervene and take over the clinic because it didn't have licensure. When the Attorney General came to present his budget to the Finance Committee this year, I specifically asked him, would that have been easier for him to intervene in the case, in that case, had it been licensed by the Department of Health? And he said, absolutely it would, because the Department of Health could have intervened through licensure instead of through the courts with him, which would have saved the taxpayer a considerable amount of money. But what this bill would do, it would simply, physicians that currently practice IVF are physicians. Those physicians would simply receive a certificate from the Department of Health in order to practice IVF for their work. Let me go back and start over. At first, it requires the fertility clinic in Tennessee to obtain a certificate, from the Department of Health by submitting the information regarding their verification as a fertility clinic with SART membership. To give you an idea, SART membership is a national entity who promulgates rules as it relates to the practice of a SART and IVF. It just says that they have to be, that verification of the fertility clinic has to be done. They have to have an emergency plan for the transfer of embryos should the clinic close permanently for any reason. The proof of passing the most recent laboratory inspection from the College of American Pathologists or the Joint Commission on Accreditation from healthcare organizations. This is not a Department of Health entity, but it's how they currently have their laboratories inspected now. They simply provide that information to the Department of Health to prove their accreditation. They'll also submit a cycle of specific clinic outcome data verified by their medical doctor with the permission to close such data and allow that data to be validated. The accreditation of an embryology laboratory, which occurs every 2 years. The medical director of any new practice must be a reproductive endocrinology and infertility subspecialty certified by the American Board of Obstetrics and Gynecology and an active candidate for subspecialty certification, unless they are a member of SART prior to January 1st of 2000. And there will be a strict guidance of adherence to all SART guidelines, which are the current national guidelines. And finally, they must be licensed to practice medicine or osteopathic medicine, and the board shall be board certified in obstetrics and gynecology by a member board of the American Board of Medical Specialties. They must demonstrate substantial clinical experience in ART or assisted reproductive technology procedures and maintain continuing education, much like most physicians do. This amendment also requires fertility clinics to follow the clinical practice guidelines and professional standards associated with genetic testing, which this is their own SART guidelines. A lot of discussion regarding this description last year brought a lot of consternation, but this just references and says that they shall adhere to those SART guidelines, which are the current guidelines that they all operate on. The idea behind this bill is really to allow for oversight so that facilities can't operate like the one did here in Nashville without some kind of state oversight or governance. With that, Chair, lady, members, I'm happy to attempt to answer any questions that members might have.
Okay, I think I have Chairman Gillespie that has a question for you.
Thank you so much, Madam Chair. And Chairman Williams, thank you so much. I know we've talked about this a lot in the past. as far as the stand, and I forget the terminology here, the CAP or the JCAHA acronym for the inspections.
Yes.
How many Tennessee fertility clinics currently are inspected by those bodies or in some way?
Chairman Williams.
Thank you. If they're currently accredited by SART, all of them do.
Okay.
But that's the reasoning for the SART accreditation is the reasoning behind that as well. They, for instance, that this is how that they govern their laboratories, either through the Joint Commission or the other.
Follow up.
Yes.
Okay, I understand that. Okay, but if there are organizations that currently are not, that would need to be, who pays for that? How much would that cost? Would that cost be passed on to the patients?
Chairman Williams.
Thank you. They have a period of time in which they can become SART accredited, but the cost of that accreditation is borne by the IVF currently if they're SART members.
Okay, thank you so much.
Anyone else got any questions? Chairman Clemens.
Thank you, Madam Chair. So I'm sorry, I've been trying to read this amendment. Are we pretty much requiring a state level requirement that the federal government already requires?
Chairman Williams.
The federal government does not require anything.
But doesn't the federal law already require CLI certification?
Chairman Williams.
It suggests it, but it doesn't require it.
So, but and those inspections, those lab inspections, if they're compliant with those lab inspections under CAP or the Joint Committee on Accreditation of Healthcare Orgs, you have to do those to get SART certified, right?
That's correct.
And you just said most of them are SART certified? Or is that, am I mischaracterizing what you said?
No, in order to be a member of SART and the that accreditation, because of the SART guidelines, they have to have their laboratories inspected. When I met with the clinics regarding this, one of the things they absolutely unequivocally did not want happen is their laboratories to be inspected by someone who wasn't qualified or SART specific. That way, because they were already having these inspections, all we simply did is say that they would submit those submissions. They would submit those reports to the Department of Health. We're not creating any new laboratory inspections because, based upon my understanding of what these IVF clinics do, it's a very small, compact laboratory with very few people. In most cases, many physicians don't even enter the room. And so opening that laboratory room to people for inspection would be, could possibly have a negative consequence for the laboratories. And I simply did not want to impugn them in that way.
Chairman Clemens.
Okay, so on page 3 of your amendment, I guess we were in 2102. In sub B, it says to receive a certificate from the Department of Fertility Clinic must submit the following. And then that's the verification provision you just said, emergency plan, and then proof of passing the most recent lab inspection. Is there a guarantee that the department will certify them if they provide those?
Chairman Williams.
This just says to receive a certificate, that's what they need to provide. But what is the discretion on the part of the Department of Health there to deny them a certificate, even if they check those 3 boxes?
There isn't I don't think it is discretionary. It says that each fertility clinic operating the state shall obtain, and they have to obtain once they provide the submission of those 3 3 items listed in the bill.
Okay. And it said they shall obtain the certificates. I understand that. But the part about the department giving them a certificate, I would prefer personally for that to say the department shall certify them if they do these 3 things. Following that, do we know, and I don't know if Representative Gillespie asked yes or not. I mean, again, going back, how many in the state of Tennessee are not CERT certified? Do we know that? Or
Chairman
verified?
Williams.
I do not know that.
Okay. And do you have any ideas to what the costs are? Because if the federal regulations are suggested, based on the information I've been provided, the cost can range 1,300 to 16,500 with was that a average around 7,250 or a median around 7,250? So are there any additional costs beyond that for these clinics? And if so, what would those be?
Chairman Williams.
At this point in time, I don't know what those additional costs would be, but it would seem very peculiar or odd for an IVF clinic to be practicing under those permissive guidelines under SART in the state if that were the guidance before. If the very fact that they're not SART certified and they're not having laboratory inspections, I think that's the point we're making, is that they should. It was suggested that they do in the federal guidance, but we're just saying they shall follow those guidelines here for the very purpose in which the physician or the clinic director at the clinic here in town that was shut down, they weren't SART certified. And so there was no guarantee that the way they were operating there, providing services to citizens, was being done in an appropriate fashion.
Okay. Thank you, Madam Chair.
Mhm.
Sponsor.
Thank you. Thank you, Chairman Clemens. And I would just make a comment that when I toured the big IVF clinic here in Nashville, they were very much in favor of all of them being CERT certified. That was one of their big issues that they would like to see us as a state moving forward on. And to make reference to what Chairman Williams said, because the one that was acting bad was not certified. So that was the big thing, that the big one here did really want us to push the certification. I mean, so Chairman Terry, you had the question?
Yeah, thank you, Chair Lady. And I want to thank the sponsor for working with all the stakeholders, everyone involved, coming to us, talking to us about that. I do want to help hopefully clear something up from this. And it goes back to a couple of the previous questions in that, if that standard's being met, which they want, the community wants that standard to be met. And then the certification, it's called a deemed status. Deemed status. If you've met the standard, you've already deemed status, you get the certification. So my understanding is that's not to drive up any cost to the IVF clinics. Is that correct?
That's correct.
Thank you.
Okay, do we see any other questions? Wanting anyone for the sponsor? So is everyone ready to vote? Okay. Clerk, would you please open the board for a vote? Okay. Clerk, would you please close the board and announce the vote, please?
Madam Chair, you have 6 ayes, 3 nays.
Okay.
Thank you, Chairman and members.
Welcome. Your House Bill 2290 will be moving on to full health. Okay, let's see how much time we got. Okay. Let's see, which one did we roll this one?
Yeah, that's the one we wrote.
Okay. So we've got this one. Okay. Okay, next on our list is item number 4, House Bill 1943 by Representative Love. Do we have a motion and a second? Motion. Okay. Are there any amendments?
Yes, Madam
Okay,
Chair. There
would
are
you-
2 amendments.
Okay. Would
I
you
have-
like to give us both those amendment numbers?
Yes, ma'am. Drafting code 013126.
Oh,
That's the
I didn't
first
know
one.
if we could vote on both of them or, okay. Well, okay, we'll go ahead and vote on Amendment 013126. All in favor, say aye. All opposed? Okay. 013126 will be added onto House Bill 1943.
And
Okay.
also have 013331.
Okay. Do I have a second? Is there a second on it, on that amendment? Okay. We have a motion and a second on adding Amendment 013331. All in favor?
All in favor? Thank you.
Hello. We're lack of oxygen or food or something in here today. I can be all of that. Okay, all in favor say aye. All in favor say no. Nay. Okay, Amendment 013331 is added to the bill. Okay, the bill is probably before us, so sponsor, you can give us a brief description of your bill.
Thank you, Madam Chair, and thank you, members, for the attention to give on this piece of legislation. This piece of legislation, as amended, simply states that emergency rooms are not permitted to deny pregnant women treatment under certain circumstances, and that they should make their very best effort to provide treatment for them, like transferring them to another facility if they cannot treat them properly. And those amendments in there also remove any concerns about capacity. If you'll see in amendment number 013126, it specifies the capacity includes the hospital's availability of appropriate personnel, equipment, and on-call specialty coverage necessary to safely treat the pregnant woman. And also in the other amendment, it references that a physician, qualified medical professional, or hospital employee is not subject to civil penalty, licensure, sanction, or other adverse action under this section if the physician, qualified medical professional, or hospital employee acts in good faith and exercises reasonable clinical judgment based upon the information available at the time care is rendered or a transfer decision is made. And that, Madam Chair, is the bill as amended.
Okay, we've got a bit of something we need to clear up here. So you had two amendments on here, and the second one voids the first amendment that you wanted, that we added on to it.
Is that 013126?
No, 013, okay, the 01333 voids out the 01312.6.
Is that because we added a second, or so should I, okay.
So we're going to go out of session here from legal, just to get this clear and that we're on the, okay.
Heather Oswald, Legal Services. So the committee adopted Amendment 13126 and then subsequently adopted Amendment 13331, but they rewrite the same provisions. And looking through that, the difference between the two that I can see right now is the definition of capacity.
Correct.
So it depends on, so at this juncture, I believe that we're on Amendment 13331 with that language. Since the committee adopted that one, it essentially voids 13126. If that's your intention.
I think the First Amendment is the one that needs to be on. I was told that both need to be on there, though, but because.
So Representative Love, would you like to roll it a week to clarify that?
Well, I heard earlier that this was the last meeting.
No, next week is.
Okay.
So next week is the last one. Would you like to roll it till next week, or we can? That's right, we are. I'm sorry. So
Let me see what. Can I phone a friend right quick and then get back with? We're gonna, sorry, Madam Chair.
So we're going to go back into session. And so which amendment do you want us to go with today?
013331.
Okay, all right. So has everyone got that? We have added 013331. So are we good to roll? All right. Okay, you may proceed then.
That was
Or
it,
did
Madam
you,
Chair.
so you were done?
Yes, ma'am.
Okay, so we're just now taking questions from anybody with sponsor. Okay, Chairman Terry.
Thank you and appreciate you bringing this. And I guess my question for you, obviously this goes back to EMTALA, which I believe, Emergency Medical Treatment and Active Labor Act, which covers this, which I think passed back in 1988, but it's not your intent for this to be more burdensome on the providers or anything like that?
No, sir.
Well, thank you.
Did you have a response or?
I did. I responded. I said no.
Okay,
Yes, ma'am.
okay. Chairman Kumar, you have a question? Yeah.
Thank you. Considering that this situation is covered under EMTALA, what is the need for us to pass a law?
Well, I think we had a situation where last year someone was denied treatment, and this is trying to clarify that they need to provide treatment in emergency rooms if someone presents and is pregnant, and or provide transportation if they find that they are not able to provide those services at that particular facility.
Chairman Kumar.
Can you be more specific? What particular condition was the treatment denied for?
The woman was pregnant and the facility denied her treatment at the facility.
Was that treatment related to abortion care?
No, it wasn't. It wasn't related to abortion care at all.
Okay. There would have to be a reason for treatment to be denied by a hospital or an emergency room. There are a number of laws and moral obligations under which that should never happen.
I agree. But sometimes folks still do that.
So you would think that would have been reported under EMTALA?
I don't know what the particular patient did after that. I was reading from a news article that this happened in Jonesboro, Tennessee last year.
Okay. Well, that's my concern, is really that considering that these situations are covered under EMTALA, by passing our own law, are we creating confusion?
Representative Love, you got any response? Okay. Chairman Kumar, do you have?
That was my concern
Sure.
about it is.
Do you think that this particular bill would confuse doctors and hospital personnel on what their obligations are?
Or would it open a doorway for abortion care?
She wasn't married. That's why she was
There'll be no outbursts like that. The next one will be asked to
So
leave.
if I can, Chair Lady,
Yes, you may.
I would hope that the committee would appreciate the intent that I'm bringing this bill in. When I got elected in 2012, we oftentimes asked members, what is your legislative intent? And we go through a series of questions about what are you trying to do with this bill? And I can promise you, this has nothing to do with opening a door for abortion care. This is about a situation where we know that a woman was denied care, prenatal care, in Tennessee because she was not married. And that was what the doctor said. And so we're talking about a situation where we want hospitals, when women present, to treat them, if they can't, to transfer them, as the bill says. It doesn't impose upon them any civil liability, doesn't impose them any licensure problems, but simply says that they should go ahead and do this. And we have an instance that it did happen in our own state. And so I promise you, this is not a side door opening of anything about abortion care. This is simply trying to say, if we're pushing for women who are pregnant to be treated by hospitals and emergency rooms, then when they show up, then we'd want them to be treated and not denied care.
Thank you, Representative Love. I very clearly understand and agree that that's not your intent and you're not trying to do that. You're trying to pay attention to a situation that happened and you don't want that to happen again, and we don't either. You know, all of us are with you on that. I wonder if a clarification is needed here that this was not applied to that situation, because EMTALA is Emergency Medical Treatment and Active Labor Act. It's a federal law and it's very rigidly enforced. The hospitals monitor that situation very much. And I was not aware of the fact that the woman was not married, and that's certainly no reason at all to refuse treatment. It's a human thing to do, and it's our oath and our duty to treat a person. And we would definitely want these patients who present to the emergency room to be treated. However, do you see the concern that was relayed to me about it by a constituent, that would this open that door? So if you want to add language and amend the situation to forestall that objection, I would appreciate it. I think your heart is in the right place, and I really respect you.
Representative Love.
Sure, and I don't mind rolling it 1 week if I can get that amended language on there to put everyone at ease that this is not the intent of that.
Well, thank you.
Second.
Thank you.
Okay, we've got a motion and a second to roll it for 1 week. Yeah. All in favor?
Aye.
All against? Okay, we will roll House Bill 19453. I couldn't see that. It was till next week.
Okay, thank you, Madam Chair,
Thank you.
committee members.
Let's see, we have 10 minutes, kind of 5 minutes left. Representative Keem is next on the list, and for House Bill 0179. Hey, you have a motion and a second. Are there any amendments? No, don't see any. Okay, so your bill is in proper motion before us, so proceed with the description of your bill.
Thank you very much, Madam Chairwoman. I come to you with this bill as a health bill grounded in compassion, clarity, and medical reality. This legislation provides explicit exceptions in Tennessee law in cases involving the life of the mother, rape, and incest. First, with respect to the life of the mother, ensures that when a pregnancy presents a serious risk of death or substantial and irreversible impairment of a major body function, physicians have clear statutory authority to act. In emergency medicine, hesitation can cost lives. This bill provides clarity where clarity is necessary. Secondly, in cases of rape and incest, We must acknowledge the trauma. National data consistently shows that thousands of pregnancies each year result from sexual violence. Survivors already endure unimaginable harm. Public health policy must not compound the trauma. The Tennessee General Assembly is approximately 90% male. Yet the medical and physical consequences of pregnancy are borne entirely by women. This bill is not about politics, it's about humility in policymaking. When a body overwhelmingly composed of men legislate on matters that uniquely affect women's bodies, we have a heightened responsibility to ensure our laws reflect medical science, lived reality, and compassion. House Bill 179 does not dismantle Tennessee's framework. It does not create broad access. One of the items that in regards to our law as it is now, is a Class C felony. If we're saying that if someone, a doctor, goes beyond what is outlined here, that Class C felony, which is 3 to 15 years, comes into play. It creates narrow, clearly defined exceptions for the most tragic and medically urgent circumstances. Please, public health policy must account for reality, for emergency room, for trauma survivors, and for physicians trying to save lives. House Bill 179 ensures that in the rarest and hardest cases, Tennessee law provides clarity in crisis and compassion in tragedy. Thank you, Madam Chairman and the committee.
Okay, we have someone that has signed up to speak, and we will go out of session and hear from her. Her name is Rebecca Howard. Is she here today? You'll have 3 minutes to come to the microphone, state who you are, who you're with. You'll have 3 minutes.
Hello, Chairman and members of the committee, thank you for allowing me to speak today. My name is Rebecca Howard, and I am here in respectful opposition to HB 0179. I want to begin by acknowledging something very clearly. Rape and incest are horrific evils. My mother was 19 years old when she was taken advantage of and raped by someone she trusted and knew. It was violent, unjust, and devastating, and no woman should ever endure that. But I stand before you today as the child conceived in that rape. I did not commit the crime against my mother. I did not cause her pain. And she did not see me as the perpetrator. She saw me as her child. I recognize that these situations are unimaginably painful, but ending the life of an unborn child does not undo the violence that was done. It creates another loss, another life ended because of a crime someone else committed. We can and should offer women who have experienced rape or incest compassion, counseling, protection, medical care, and tangible support. And we should pass or pursue justice against offenders with full force. But I respectfully believe that compassion for the mother does not require ending the life of her child. I am living proof that a life conceived in violence is still a life with purpose and value. Please consider this message that this bill sends, that some lives are less worthy of protection because of the circumstances of their conception. Thank you for your time and your service.
Thank you for being so brave to come and share your story. Do we have anyone on the committee that has any questions to our guest? Chairman Kumar.
Mr. Becker, thank you for coming. We admire your courage and commitment to life. God bless you.
Does anyone else have anything? Again, we thank you for coming. And yes, your life does matter. So thank you very much. So we will go back in session. And to our sponsor.
Thank you, Madam Chair. As I said, this would be in rare circumstances. And when we talk about the life of the mother, I don't know if we take it as seriously sometimes as we should. Women do die in situations where health care is not provided. And we've had situations, not in our state, others where Louisiana, where a lady was forced to carry a dead fetus. In Tennessee, we've had a woman to have to be driven by ambulance for 6 hours. I mean, body breaking down because the pregnancy created a situation that she possibly could not live. We're not proposing that any child dies. We're saying that in certain circumstances, whether it's going to be either the mother or the child, a decision has to be made. Thank you, ma'am.
I would ask the lady back here in the back to put your sign down. Okay. Chairman Clemens?
Yeah, thank you, Madam Chair. I appreciate it. And just to clarify, does your legislation require a woman to get an abortion in these instances, these horrific instances?
No, sir.
Representative
sorry.
Hakeem?
I apologize. All right. Thank you very much, ma'am. It's not a requirement. This is something that has to be decided between that lady, maybe her physician or her family, as to what takes place after that point.
Thank you, Madam Chair. And you know, in most cases, it's going to be between her and her own faith, right?
Yes,
and she's going to make this decision. And this bill, you know, we sit here in the state of Tennessee, we do have the worst maternal mortality rate in the country. We do have instances that we just discussed where women are turned away by healthcare providers for what I consider to be inexcusable reasons. We continue to deprive women in this state of dignity and equal rights. And this bill reads to me, and I know I'm not going to change many people's minds up here, but this bill reads to me as a bill about dignity and compassion for women. And I appreciate you bringing this legislation, because until we start respecting women, they're never going to get the dignity and the equality that they so badly deserve. And I appreciate that this is a step in the right direction, that in the most horrific instances that will have a direct impact, in most cases, I'm not going to say every case, on that woman's mental health, the health of the fetus, the health of the woman. This is a bill about protecting Tennesseans, so I appreciate it. Thank you.
Thank you, sir.
Representative Cheryl, do you have a question?
Thank you for this opportunity. To listen to this young lady right here that's sitting up here today, your mother done the right decision. We have a beautiful young lady that's sitting right here today that your mother done the right thing. If she'd have done the wrong thing, you wouldn't be sitting here. I appreciate your mother. Appreciate you having the courage to come and talk today to us, because as we know, life does start at conception. We know that. Tragic what happened to your mother and her situation. But I'm sure glad that your mother done the right thing. And thank you for today.
Representative Hakeem?
Thank you very much, ma'am. I'm not talking about any situation. We're saying in the instance which you just brought up, if it was a matter of the life of the mother, should that option be on the table? Or should she die, to bring another life into the world? Who's going to take care of that life? Look at the state of Tennessee, not just Tennessee, but across the nation, at our foster care and things of that nature. Are we doing all we can do for the children who are already here? So again, this is targeted to deal with extreme situations. Thank you very much, Madam Chair.
Okay, being no more questions and we are out of time, are we ready to vote? So clerk, would you please open the board up for a vote, please? Okay, clerk, would you please read the vote? Okay, the ayes have it, the vote fails by 8-2 and moves, will be staying here. So won't be moving any further. So, and then all the remaining bills will be moved to the next calendar. And I have a motion to adjourn.